includes acute inflammation and chronic inflammation and repair of tissue. Acute inflammation, when we say acute, it means that it is transient and early response to injury. So, in any type of inflammation, being acute or chronic, we have some chemical mediators. Chemical mediators are important, and types of cells that respond. So, in acute inflammation, neutrophils are the predominant types of cells, and we have special types of chemical mediators that function here. Cardinal signs of acute inflammation. This is a clinical part in acute inflammation. You see, signs of acute inflammation, it includes redness, and acute inflamed area is red, is called erythematosus. Redness or rubor, and it shows swelling or the old term tumor, and it associated with warm skin color. These are Italian words. Warm skin, when you touch the inflamed area, is warm. Its another name is calor, and it's painful or dolor. Again, an Italian word, pain or dolor. So, these are signs of acute inflammation: redness or rubor, swelling or tumor, warmth or calor, and pain or dolor. Now, so imagine this is a vessel, and the main cells in acute inflammation are neutrophils. So, leukocytes or white blood cells. We have different types of leukocytes. One of them is neutrophil. Neutrophil has a multilobulated nucleus. So, neutrophils in blood, this is a vessel. They circulate, and these are red blood cells. Imagine these are red blood cells. So these are neutrophils. These are red blood cells. This is a vessel. Now we have an injurious site here, for example, in epidermis of skin. This is epidermis. So skin tissue composed of epidermis and here dermis. Imagine there is an abrasion here, an injury. Epidermis is composed of a stratified squamous epithelium. So multi-layered squamous epithelial cells. And at the basal layer, this is the basement membrane of epidermis. And in this basement membrane, there is the basal layer of these squamous epithelial cells, which can regenerate and make these squamous epithelial cells, the basal layer. Now imagine there is an injury here, some part of this epidermis is injured, maybe also the basal layer is injured. It depends on the deepness of the injury. And some bacteria, such as some bacilli, rod-shaped bacteria, these bacteria can enter the tissue. These bacteria can have way to the dermis or a foreign body. So a microorganism such as bacteria or a foreign body. Foreign body such as a piece of glass tissue, and anything that is foreign to our body can contaminate this injured area. So normally here in the dermis we have some macrophages. They are here. Now what happens when there is an injury here? These neutrophils in the vessel, they have the duty to come near the vessel wall and then exit the vessel wall and migrate to the injurious site to kill the bacteria. This is what to be done after an injury is seen somewhere in body. So first, these neutrophils should come close to the vessel wall that is lined by endothelial cells. These are endothelial cells that line the vessel. So neutrophils, they come close to the vessel wall, and this is called margination. These central neutrophils should come close to the endothelial cells. And what is the stimulation for this margination? In inflammation, a protein is increased in blood called fibrinogen. And this causes the red blood cells to bind each other and make for a pattern like this. It is called rouleau formation. Rouleau formation, or like stacks of coin. So these red blood cells bind each other due to inflammation, which causes increased fibrinogen in blood. And this rouleau formation of red blood cells forces their neutrophils to the vessel wall. This is called margination. So the neutrophils come near the endothelial cells. And now they should have some receptors to bind to endothelial cells. These are called selectins. Selectin. Because these are leukocytes, they are called L-selectin. L means leukocyte. But endothelial cells also have selectins, but they are called E-selectin endothelial or P-selectin. Both E-selectin and P-selectin on endothelial cells. So with margination, selectins, which are adhesion molecules, selectins. These are both present on neutrophils and endothelial cells and also platelets. That's why we also have P-selectins. But endothelial cells have both E-selectin and P-selectin. So these can bind each other. Imagine this is a neutrophil that has come closer to the endothelial cell and has bound by its L-selectin to E-selectin of endothelium. But this binding is not strong, it's weak. That's why when blood flows, again this neutrophil separates from the endothelial cells, it changes its position and then can bind somewhere else to another endothelial cell here by its L-selectin to E and P-selectin here. And this separation and binding repeats. So it causes a rolling of these endothelial cells. Since this kind of binding is weak, it causes rolling. So this neutrophil attaches and detaches. Attaching and detaching is repeated. So this part is called, after margination we have rolling. Rolling, separation, binding, or attaching, detaching. Why? Because this kind of binding is weak. So after margination we have rolling of cells. But there are other kinds of adhesion molecules on the neutrophils called integrins. For neutrophils, it is called beta-2 integrin. Beta-2 integrin. So beta-2 integrin this time binds to another adhesion molecule here on endothelial cell, which is firm adhesion molecule. So this time, this neutrophil can bind through beta-2 integrin to firm adhesion molecule. So here it binds by its beta-2 integrin to this firm adhesion molecule on endothelial cell, which include ECAM and VCAM. Its adhesion molecule, cellular, endothelial cell vascular. This VCAM is more present on there are for neutrophils and these for other inflammatory cells such as eosinophils. So beta-2 integrin of the neutrophil is attached to firm adhesion molecule on endothelial cell, and this time the type of binding is strong and it's called firm adhesion. So margination, when the cells, the neutrophils come close to the endothelial cells, a weak binding which causes rolling through the different selectin molecules, L-selectin on neutrophils and P and E-selectin on endothelial cells, and then firm adhesion by beta-2 integrins on neutrophils and adhesion molecules on endothelial cells cause a type of adhesion which is firm. Then after this type of adhesion, this neutrophil should pass through the vessel wall. After this firm adhesion, this neutrophil should pass through the vessel wall by making a space between these endothelial cells. So these endothelial cells are close to each other, but by secretion of some chemical mediators such as histamine, this histamine contracts the endothelial cells, and a gap or a space is developed between endothelial cells. So this space helps the neutrophil to be able to pass through the vessel wall. This type of motion migrating through the vessel wall is called transmigration. Or diapedesis. So the migration of this neutrophil through the vessel wall is called transmigration. This changes its shape when it wants to pass through the vessel wall and comes here. This is called transmigration. But here, in addition to histamine, which causes a gap between the endothelial cells, there are some other type of molecule that helps this transmigration, and it is called PECAM, platelet endothelial cell adhesion molecule, which is both present on neutrophils and endothelial cells. So presence of this type of molecule on both helps transmigration of neutrophil through the vessel wall. So histamine for making a gap, and another type of molecules called PECAM, both on neutrophils and endothelial cells. It helps binding of neutrophils to endothelial cells and transmigration. And there are also some enzymes such as collagenase that can dissolve the collagen that is present under this endothelial cell. It can make some part of the basement membrane disappear, and the neutrophil can pass through the vessel wall, and this is called transmigration or diapedesis. So again, we review the names: margination, rolling, firm adhesion, transmigration or diapedesis. So in acute inflammation, when a neutrophil wants to exit the blood vessel, we have these steps: margination, rolling, which is a weak adhesion, firm adhesion, and then transmigration. So after these steps, imagine the neutrophil is here, out of the vessel. Now what? This neutrophil should move here, but how? So here we have some chemical mediators. So some chemical mediators are secreted by these bacteria and also by the neutrophils themselves and other inflammatory cells such as these macrophages that are present here. And the surrounding tissue as well as the fluid that comes out of the vessel together with this neutrophil, the edematous fluid. So these cells are not alone. Together with transmigration, some fluid exits the vessel, an edematous fluid that causes the edema or swelling, and this kind of edema is called exudate, because we have two types of edema, exudate and transudate. When we notice a patient has edema on, for example, legs, face, or in an inflamed area due to infection, these are all types of edema but different from each other. An exudate is seen in acute inflammation, but the type of edema that is seen in a patient who has kidney failure, renal failure, or heart failure, which causes facial edema or edema in extremities. You have some people, you have seen some old people who have edematous legs or have edematous eyes. I mean the tissues around the eyes are edematous. These types of edema are transudative edema. They are due to renal or heart failure. And the type of tissue edema there is transudate, but in acute inflammation is exudate. But the main difference between these two types of edema is the level of protein. Exudate is high in protein and transudate is low in protein. So the main difference between two types of edema, exudate and transudate, is that exudate is a high protein fluid. So this exudate, which exits the vessel together with neutrophils, it contains high protein level. These proteins and some other molecules can act as chemical mediators. So the inflammatory cells, the bacteria, the surrounding tissue, and also the exudate, all can have chemical mediators that stimulate this inflammatory cell to have a directional movement toward the injurious site, which is called chemotaxis. So after transmigration, we have chemotaxis. This chemotaxis is stimulated by chemical mediators. They cause a directional movement toward the injurious site here, and this step is called chemotaxis. So margination, rolling, firm adhesion, transmigration or diapedesis, and then chemotaxis by chemical mediators. These chemical mediators are different with different names. And this exudate, in addition to having chemical mediators, has some other duties as well. If the bacteria secrete some toxins such as endotoxin, this exudate can dilute that toxin level. So one of the actions of this exudate is dilution of the toxin in the injurious environment. So it has chemical mediators, it can dilute the toxin. And another duty of exudate is having opsonins. What is an opsonin? In immunology, this term is used. If a bacteria is sensed by macrophages and neutrophils, which are also called phagocytes, they phagocytose this bacteria. The end result of the movement of this neutrophil toward the injurious site is what? Is to kill this bacteria, is to ingest this bacteria by the action of phagocytosis. And So the cells, the phagocytes, including neutrophils, macrophages, dendritic cells, they should sense, should feel these bacteria, these foreign bodies. And this sensing is increased by some molecules called opsonins, which bind the bacteria and foreign bodies. Imagine this is a bacteria, a bacillus. And this is a macrophage or neutrophil that have the ability to phagocytose this bacterium. Bacterium, the singular. This bacteria can be sensed by these inflammatory cells, but when they are covered with molecules called opsonins, they can be sensed much better by these phagocytes. Opsonins include immunoglobulins such as immunoglobulin G, and one of the components of the complement pathway, complements are soluble serum proteins. They are named with letter C, complement system. Complement system. Complement system includes soluble proteins in serum and also on cells that they play a role in inflammation and immune responses. So different fragments of complement are named with the letter C and a number after this C. C3, C5, C9, C8. So one of the complements that is important to be an opsonin is C3 and B. After 3 we use A or B. So C3b component of the complement can also be an opsonin. And also some proteins such as C-reactive protein. So different kinds of molecules such as immunoglobulin G, C3b, and CRP protein can act as opsonins, so they can bind this bacterium, for example. This IgG is an antibody, IgG. So imagine this is an IgG. Or C3b, or a protein such as CRP. So a foreign body or a microorganism, a bacterium, can use each of these molecules, C3b or CRP or IgG, to bind these phagocytes, because these cells have receptors for these. The receptor for immunoglobulin G and for all immunoglobulins is called Fc receptor. Because an antibody, if you know the structure of an antibody or immunoglobulin, this fragment of an immunoglobulin is called the Fab part, and this part is called Fc. Fab means antigen binding site, fragment of antigen binding. But this part binds cells. So this part of this antibody, which is Fc, can bind to Fc receptor of phagocytes. And also these cells have receptors for this C3b or for the protein. So by binding this bacterium or a foreign body with special molecules which are called opsonins, these phagocytes can sense this bacterium much better for doing the action of phagocytosis. And this action of binding of opsonins to bacterium is called opsonization. So one of the other duties of an exudate is having opsonins for opsonization of the foreign body or microorganisms. So the edematous fluid, the exudate, have some duties which helps the inflammatory reaction to be performed. So this is exudate and its duties and the concept of opsonin, the opsonin molecules, the action of opsonization, and the receptors that are present on phagocytes for binding to the opsonins. Now, these chemical mediators act on neutrophils, which is called, the result is called chemotaxis. But what causes the neutrophil to move? These chemical mediators bind to neutrophils and cause increased calcium level inside the cell. So that's the change that is seen inside neutrophils. And increasing calcium level in neutrophils causes motility of neutrophils. So what causes the neutrophils to move? Calcium. Increased calcium level in neutrophil by the action of different chemical mediators causes movement of neutrophil. So neutrophil can't move by itself. Something should change inside the cell to move. So these chemical mediators can make the neutrophil to move. This movement, this directional movement toward the injurious site is chemotaxis. So at this step, the neutrophil is here. By the step of chemotaxis, the neutrophils reach here. So margination, rolling, firm addition, transmigration, chemotaxis, and then here they come close to the bacteria to do what? To do phagocytosis. The last step is phagocytosis. So here the neutrophils and also the macrophages that are present here have the ability to phagocytose these bacteria. This is a neutrophil with multilobular nucleus, and this is bacteria that by the action of chemotaxis, the neutrophil has come close to the bacterium. And this, you remember, this bacterium now is opsonized by binding IgG or C3b or CRP. Then they come close and they bind by any of these receptors to the neutrophil. And now another reaction that is seen is engulfment of this bacterium. So at the other step, this bacterium that is bound to the neutrophil is engulfed by the phagocyte. So by this opsonization, it makes it easier to bind the bacterium to the phagocyte. And little by little, this is covered and makes a vacuole inside the neutrophil. So after this engulfment, so this is phagocytosis. This last step is phagocytosis, through which the bacterium or the foreign body should be degenerated, the bacterium should be killed. Now this is called engulfment. Then it covers it completely and makes a vacuole here, which is called the phagosome. Something like autophagia. It's similar to the processes of autophagia. The phagosome is made by making a vacuole that contains this bacteria. And little by little, the lysosomes inside the neutrophil, which contain hydrolytic enzymes, they fuse this vacuole, lysosome. So the lysosome inside the neutrophil fuses with this phagosome and make phagolysosome. And then its enzymes can kill the bacteria by making the phagolysosome. But there are two types of killing through phagocytosis. One is oxygen dependent and the other is oxygen independent, and we will explain it as well. So these are the steps that are seen in acute inflammation. There are some other points here that I will show you here. So in acute inflammation, there are two main changes. Cellular changes that I explained you, the neutrophils that do the different steps of rolling, margination, rolling, adhesion, transmigration, chemotaxis, and phagocytosis. And the vascular events and cellular events. The vascular event is that a venule, if you remember, the vessels are arterial type, venous type, and those small branches that bind our arteries and veins together, which are capillaries. So first, the vascular events in acute inflammation, the sequential vascular events in acute inflammation is vasodilation of arterioles. First, there is, in acute inflammation, there is dilation of arterioles. And this is called by chemical mediators such as histamine and other vasodilators such as nitric oxide. Nitric oxide is a free radical, has action of vasodilation as well. Then, I am explaining the vascular events in acute inflammation. What I explained you so far on the board were the cellular events. And now the vascular events together with the cellular events are vasodilation of arterioles. This causes increased blood flow. And then this increased blood flow causes increased permeability of the venules. Because in veins, so arteriole is a small artery, venule is a small vein. So together with these cellular events, we also have vascular events, which are arteriolar vasodilation. So an arteriole, before stimulation has this diameter, and after stimulation it dilates. So this is called the dilation, which causes increased blood flow. This increased blood flow then causes increased venular permeability. Because in venules, the endothelial cells that line the vessels have more space between them in comparison with arterioles that have tightly ordered endothelial cells. So the change in arterioles is dilation, but this increased blood flow due to vasodilation causes increased venular permeability in venules, because the structure in vascular structure is in venule is different. The endothelial cells have some space between each other, and this increased venular permeability is seen in venules. That's why it causes edema formation. This exudate is developed due to increased venular permeability in acute inflammation. So this increased blood flow causes increased venular permeability, and as I said, some chemical mediators are secreted such as histamine and nitric oxide. This space becomes more, and then the cell can transmigrate. So remember two important changes in acute inflammation: cellular change and vascular change. The vascular change, if you are asking a question, is arteriolar vasodilation and venular increased permeability, not increased permeability in arterioles, in veins, in venules, because in some questions they change the places of these terms and may confuse the student. So you should know that vasodilation is important in arterioles, but increased venular permeability, increased permeability in venules, because there is some space or gap between the endothelial cells, and they are easily spaced by secretion of chemical mediators. So this is the vascular events in acute inflammation that is also important together with cellular event. That's why we have edema or swelling of tissue. The swelling of tissue is one of the cardinal signs in acute inflammation. So these vascular events, arteriolar dilation, venular increased permeability, swelling, which causes swelling of tissue, and edema. And the sequential cellular events in acute inflammation, I explained you about this. So margination, of neutrophils, I explained you the Rolo formation due to increased fibrinogen, which it causes binding red blood cells to each other, making the Rolo formation, which mechanically force the neutrophil toward the vascular wall. It causes margination, and then rolling, the importance of the molecules selectin, L-selectins, E-selectin, P-selectin. This picture shows these Rolo formation. You see Rolo formation, then rolling, that the neutrophils separate and bind, attach and detach, and then firm adhesion by beta-2 integrins in neutrophils and beta-1 integrins in other inflammatory cells such as eosinophils. And the presence of PECAM molecules, PECAM1, that is present on both endothelial cells and neutrophils, and this causes transmigration. You see this exudate, this edematous fluid high in protein, that is also seen due to increased venular permeability. Now, after transmigration, we have chemotaxis due to secretion of chemical mediators by bacteria, by the inflammatory cells, the tissues, and also some molecules present in the exudate. Here it names some of the chemical mediators such as interleukin-1 and tumor necrosis factor. These two molecules are very important. They are important also in formation of fever, interleukin-1 and tumor necrosis factor. These stimulate expression of selectin ligand. Anytime that we study some new mechanisms, some new molecules, then there are some diseases that are caused by deficiency of these molecules. So we will also see some diseases that are due to deficiencies of some of these molecules. Firm addition in the venules is due to the neutrophil expression of beta-2 integrins. And the other molecules on the endothelial cells are called integrin addition molecules. And here again, names of some other chemical mediators such as C5a, C complement, 5, the number after complement, and A, C5a and leukotriene-B4. These are active, the beta-2 integrins are activated by these molecules. And I said that these worm addition molecules on endothelial cells can be ECAM or VCAM. And the ECAM is for beta-2 integrin and VCAM is to bind to beta-1 integrins on eosinophils, monocytes, and lymphocytes. So beta-2, remember especially beta-2 for neutrophils. Now, as I said, when we talked about adhesion molecules, we have some disorders called leukocyte adhesion deficiency disorders, type 1 and type 2. Leukocyte adhesion deficiency type 1 is deficiency of beta-2 integrin, and type 2 is deficiency of E-selectin, endothelial cell selectin. Again, remember that some molecules have different names. Beta-2 integrins is also called CD11A, CD18. CD is cluster of differentiation. These markers were first used for lymphocytes, and then they are used for other cells as well with different numbers. So these two diseases, this is the picture. A skin infection in a patient with leukocyte adhesion deficiency type 1. So beta-2 integrin is deficient. That's what is the result of deficiency of beta-2 integrin. There will be no firm adhesion and transmigration, and so no pus formation. The patient will have no pus, no accumulation of neutrophils in the injurious site. Do you know what is pus?
Yes. Yes. Okay.
This pus, this yellowish material that is seen in pus, is absent. You see in this lesion we only see redness, but no pus fluid.
But under the black ones have.
What?
Under the black.
Under what? Under here?
Around.
Yeah. No, this is the ulceration and the addition of keratinous material, keratin on the epidermis. Keratinous, this is a keratinous change, not pus. This is a dry keratin which is present on the superficial area of epidermis, not pus. Only we have redness around the lesion. This is due to lack of chemotaxis. No beta-2 integrin caused, no transmigration, no chemotaxis. So this is seen in leukocyte LAD type 1. Another feature of this disease is having gingivitis and periodontitis, means inflammation of gingiva and inflammation of the supporting structures of teeth. So two other features of leukocyte adhesion deficiency is gingivitis and periodontitis. So what is the first manifestation of LAD disorders? Is delayed separation of umbilical cord. So when the newborn, we see the newborn, the umbilical cord should be separated at some time around 1 week after being born. But in these patients, this separation is delayed. Why? This separation is due to neutrophil enzymes. There are some enzymes in neutrophils that are important in cord separation. In this leukocyte adhesion deficiency, again due to lack of adhesion and transmigration, there are no neutrophils near the area of umbilical cord to use its enzymes for separation. So first manifestation of either type CD1 and 2 is delayed separation of the umbilical cord. And other findings are poor wound healing, severe gingivitis, and peripheral blood neutrophilic leukocytosis. Leukocytosis means increased number of leukocytes of the neutrophil type. Because margination has problem, most of the cells come to the center of the vessel. After this slide shows other steps of cellular events, transmigration or diapedesis, the endothelial cell contraction due to histamine is important. The secretion, release of collagenase, which dissolves the basement membrane. Then the presence of PECAM. The other name of PECAM is CD31, which is present on platelets, neutrophils, endothelial cells. This is important for diapedesis. And then I explained the exudate, or also we say pus. Exudate or pus in comparison with transudate, which is rich in proteins. And the functions of exudate, which one of them is dilution of bacterial toxins, another is providing opsonins including IgG, C3b, and also some proteins such as CRP, that they assist in phagocytosis by neutrophils, macrophages, and dendritic cells. This is a picture showing there is an injury here, a skeletal muscle tissue showing injury, and the vascular and cellular events which transmigrate the inflammatory cells together with exudate toward the injurious area. This picture shows, before this we have also a nice picture showing margination. Here, it's a very nice picture. This is a vessel. This is a vessel containing blood. You see all these blood area is red blood cells. And this is the vessel wall. All these multilobulated cells that have come near to the vessel wall are neutrophils. You see all of these? They have come toward the vessel wall, and this is called margination. So neutrophil margination in a vessel wall. So these neutrophils, they have adhered or bound to the venular endothelium. This is margination. This picture is acute inflammation, full of neutrophils. It's another picture is better to explain. Here, after that margination, you see that some of the neutrophils, they do transmigration. You see here that one neutrophil has transmigrated through the vessel. So some of them are still in the margination step, but some of them wants to pass the vessel. This is and this has passed. So this is transmigrating, and this one has passed. So this is early transmigration, and this picture shows that most of the neutrophils have transmigrated through the vessel. All of these are neutrophils, and this empty space that you see in the tissue is due to edema. We can't see fluid in sections, in histologic sections. In hematoxylineos, in staining, edematous fluid shows empty spaces. So having this empty space together with neutrophil shows that we have exudative fluid here, edematous fluid with neutrophils. So this is the exudation and transmigration. Then we said that the chemotaxis of neutrophils is seen that this directed migration of neutrophils. Here, chemical mediators are important, such as C5a, leukotriene-B4, bacterial products, and interleukin 8. So after the break, we will continue inflammation.
Thank you so much for watching.